Hello and welcome to the Clinical Care Options Oncology podcast. I'm your host, Kendall Schick. Today's episode features Drs. Zev Wainberg from the UCLA School of Medicine, Mark O'Hara from the University of Pennsylvania, and Paul Oberstein from NYU Langone Health. Our guests today will be discussing recent advances in pancreatic cancer management, as well as current challenges and the evolving treatment landscape. This episode is part of a larger educational program titled Pancreatic Cancer Progress, Enhancing Knowledge and Optimizing Innovations in Patient Care. For more information on Drs. Wainberg, O'Hara, and Oberstein, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about this important topic.
Hi, my name is Zev Wainberg from UCLA, GI Oncology. I'm pleased to be joined by two close colleagues, Mark O'Hara from Penn and Paul Oberstein from NYU, also GI oncologists. And we're here to talk about a disease that really we're all struggling with, which is pancreatic cancer. I think we know that pancreatic cancer continues to rise in incidence in the Western world, particularly the United States, for reasons not entirely clear. And we also know that the treatments of it remain a challenge. There has been significant changes in the treatment, the landscape, the risk factors for the disease over the last 30 years, but if we think about the challenges of cancer, this is top of list. So I'm going to just start by throwing a few ideas out there, and Mark and Paul, feel free to chime in. I think that what we've got is a situation where, by and large, the cancer is diagnosed too late, and the treatments are often, while somewhat effective, not effective in the way we think we want to be in terms of getting rid of it. It's always about chasing it. And this is a cancer that chasing it eventually becomes very challenging. Mark or Paul, do you want to chime in on some of your thoughts about how we confront this situation?
I think you hit the nail on the head. Overall, most patients are unfortunately diagnosed in the metastatic setting. And so we're talking about palliative treatment options and looking at palliative chemotherapy, unfortunately, is our mainstay. And overall having some options available to some advancements in our options over the last 10 years, but nothing that's necessarily broken the barrier to kind of be drastically changing. We're improving survival by, 1% to 2% a year, but that's not necessarily what we want to do in this terrible disease. We want to make drastic changes. And any one of us that do pancreatic cancer, that's what we're hoping for, and actually see that hope potentially in the near future.
And so, Paul, one of the challenges here in the disease, right, is that you're starting at a baseline oftentimes where the patient's symptomatic from the disease. So in a lot of cancers, as you guys know, patients are diagnosed. They don't have a huge amount of symptomatology necessarily from every single cancer it's found, whether screening or otherwise. You have some leeway with which to treat a patient, so to speak. And here I find that the majority of patients, not the minority, majority of patients, there's already symptoms from the cancer. And so, Paul, you have a lot of patients with advanced pancreatic cancer. Do you find that to be your struggle also?
Yeah, I completely agree with your point. I think it's always hard for us to know what's causing it, right? It seems in some ways like everything about pancreas cancer is bad. The ones who are resected, who have surgery, the rate of recurring is much higher than every other cancer, right? So there's early metastasis in pancreatic cancer that's out of proportion to the stage. But what you pointed out is absolutely correct. Very often, especially patients with locally advanced or metastatic disease, by the time we meet them, they've already suffered quite a systemic insult from their cancer. And sometimes you can measure that in terms of weight or inflammatory markers or cachexia, right? Something we look at, muscle wasting. Sometimes it's much less tangible than any of that, but often it limits what we can do for them from a treatment standpoint. I would say rarely we see patients who get chemo and respond, and that's how they respond, by coming back to life almost, eating more, gaining weight, but that's the minority. Right? Yeah. Most people never really get there. And so I think there's a ton that we still don't know about the mechanisms of that, what cytokines or what inflammatory pathways are happening and what we can do to treat those. There's a lot of exciting research in that, but I think we're still, not where we need to be at all.
Yeah, and I think the reality is chemotherapy is still the mainstay of this disease. The patients that we see who show up in our office usually ask us, what are our options? And, we are left telling them, for better or for worse, that chemotherapy is the only thing at this point in time in 2025 for the majority of patients that's been shown to impact survival. So I have these very candid discussions. They say, well, why am I doing this? Just to live a couple extra months. And the usual conversations obviously are all about, it's not just the months, it's about the palliation and about the symptomatology control. And so I think in that respect, we have made some progress. It's very rare that I see nowadays a patient who's decent performance status who's like, gosh, I don't want to try anything. We can always persuade them, I think for better or for worse, to try some chemotherapy regimen, because we do believe overall as oncologists that overall we're helping patients with chemo, even if it is a grind. Discussions about 2-drug regimens, Gemnab paclitaxel, 3-drug regimens, FOLFIRINOX, Nalirifox with a recent data set. These are all top of mind and laying out a combination of efficacy data and toxicity data. Mark, on your average patient, how much time are you spending talking about side effects versus Kaplan-Meier curves or median survival numbers?
I think overall, the median survival numbers, Kaplan-Meier curves, help us decide, is this therapy potentially a useful therapy? But when ultimately we're sitting in front of the patient, those numbers actually don't necessarily discuss flat out, because every patient is going to be different, and every decision we're making is going to be pertinent to that patient, what side effects they have, as we've discussed, and what side effects we expect to see with the chemotherapy regimen, and sort of balancing then the potential benefits in terms of symptomatology improvement, and then hopefully leading to also an overall survival benefit, versus the side effects that I'm expecting to see with these chemotherapies. Because unfortunately, every therapy we give, it's very, very, very rare to see a patient not have any side effects, unfortunately.
I always talk about weighing the side effects of the therapy versus the side effects of the disease, right? Because the patients that, some of them think that their quality of life is going to be better without cancer chemotherapy. But the reality is that in the majority of studies, with rare exception, the patients on chemo feel better than the patients off chemo. And that was studied in the early days, and that's been studied in just about every recent study, is that the reality here is that the cancer doesn't grow in a vacuum, right? So as the patients are not being treated, they're progressing. And so that's why I always have that approach when I talk about a patient.
I could just echo that. I think is the case. Sometimes people have a sense that they could either have 3 or 6 great months and travel the world, or 9 to 12 months with chemo. And of course, that's not the reality, right? They're not feeling well when they come. They're not just going to start feeling better. And it's true that when chemotherapy, in many studies, shown efficacy, it also shows not necessarily improvement in quality of life, but less decline in quality of life. I think the other thing that I do in my practice a lot is we're very quick to make adjustments in chemotherapy, right? There are settings where you're doing curative intent chemo for some cancers where you don't want to change anything. But here, the whole goal of chemo is really palliative, what's going to help the patient live the longest, live the best. We have to have those conversations. It's not easy, and it takes patients time to start thinking about those questions. But we're very quick to adjust chemo or delay a couple weeks for a vacation or a wedding or an event and try to get them the maximum benefit from what they can get.
Yeah, and I think that's a good point. And we're always using that in practice. We're trying to be driven by data too. So there's always this balance between, you want to intensify the chemo to see a better response, drop that number lower, whatever it is. And then, the reality is that in just about every clinical trial ever done, modifications are constant. The patients that we treat in the real world are often somewhat reflective of what's done in the studies, because no patient on the study is necessarily getting full blast chemo for the entirety of their regimen. I find that the clinical trials like NAPOLI-3, which I like the fact that there were lower doses of oxaliplatin from the get-go. I feel that's more reflective of a reality. And also, I like the fact that GemNab modifications were left to individual site discretions, because if it's preconceived that every doctor is going to manage every single patient the same way with a dose modification, it's not reflecting reality. When you allow some flexibility in patients based on toxicity management, it's overall better for, I think, patient care. That's always been my thought about clinical trial design. Mark, you have a patient with, let's say, Nalirifox, has neuropathy starting to get there. You'll stop oxaliplatin, I assume, approach it the way we would with the standard of care FOLFIRINOX type of regimen.
Yeah, no, exactly. So as Paul sort of said, quick to adapt to these regimens so that you're not necessarily leading to more permanent side effects with oxaliplatin. The neuropathy itself, unfortunately, can linger for so long. And so when it starts getting bad, I'm very quick to first dose reduce, but then actually take off the oxaliplatin with possible reintroduction down the road if we actually see an improvement in the neuropathy, but close monitoring overall, similar to what we would do with FOLFIRINOX.
Yeah. And in second line, Mark, it's obviously the toxicity parts of the discussion are even more front and center, I would imagine, for you, because now it's not just about the chemo. As I tell my patients, chemo has diminishing returns. When you get to second line, it's not usually working as well as front line. That's the reality. And so the toxicity things, I'm sure for you in your discussion with patients, take a more prominent role.
Certainly. And I don't think any one of us has a defined paradigm. Every pancreatic cancer patient, first line gets this, second line gets this, because that second line decision is based off of what toxicity occurred with the first line therapy. They have neuropathy, kind of avoiding it, maybe doing FOLFIRI or 5-FU Naliri. If diarrhea was a big side effect with their first regimen, maybe avoiding irinotecan and kind of going maybe to gemcitabine, nab-paclitaxel, something like that. And so, looking at their side effects and also looking at that point, unfortunately, coming into second line therapy, their cancer is progressing and they're going to have new cancer related side effects as well, and kind of balancing the potential benefits you can get from second line therapy, unfortunately, with diminishing returns compared to first line, but some potential benefits you may be able to get versus the risks associated with each one of these regimens.
Yep. And I mean, the landscape's changing quickly. We've got new drugs at our disposal, hopefully in the next few years. Paul, I know you've worked on a lot of RAS inhibitors and other stuff. What excites you?
Yeah, so I'm an easily excitable person. So I would definitely say, to me, the most exciting thing is that for a long time, we were doing these trials of like third line pancreas cancer, where we were sort of throwing, I'll say, marginal drugs in settings where we had no hope and we would take very little for success, and none of them succeeded. Right. And now we've got really biologically plausible and good drugs, which are not yet proven, but are much more exciting. Both the KRAS inhibitors, which all three of us have worked on a lot, we're using a lot of PRMT5 inhibitors for MTAP loss patients with very occasional good responses. The most exciting thing to me about these is that I think these drugs are going to come in earlier settings. So they've got toxicities, but they're not necessarily overlapping with chemotherapy. So if we can find a way to both identify the patients who will benefit and then figure out how to use them in first line or neoadjuvant or adjuvant settings, I think there'll be a lot of differences in how we treat pancreatic cancer.
Yeah, I agree. I mean, I think this is the most optimistic I felt about this disease. And patients know it too, right? I'm sure Mark and Paul, you get patients coming in asking for things. We never used to see that in this disease. Coming in asking for specific drugs and KRAS inhibitors, whether it's or immunotherapy drugs, that this is a opportunity for us to catch up to some of the other precision therapy cancer-related treatments. So I think we're all really excited about what the future holds. And the field is moving so fast, and that's one amazing thing. Like, it's amazing how fast the drug development's going right now in pancreatic cancer.
Thank you, Doctors Wainberg, O'Hara, and Oberstein, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program titled Pancreatic Cancer Progress, Enhancing Knowledge and Optimizing Innovations in Patient Care, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.